Dr. Shital, is she here? You can come and present. Two? Okay, fine. Okay, fine, start.
Should I start, sir?
Timer, please.
Good morning, one and all. I am Dr. Shital, and today my topic is there is a 2 years case series on Rhino orbital cerebral mucormycosis at tertiary cancer center. So there is increase in general population of fungal infection, most because of the diabetes stresses like uncontrolled and fungal organism which are common cells in human body. It will be the life-threatening infection mostly in immunocompromised persons due to lack of neutrophilic and phagocytic response. So mucormycosis is highly aggressive and invasive infection caused by group of filamentous accepted fungi. So the most common pathogen in this group are Rhizopus, Rhizomucor, Mucor and Lickettmia. So mucormycosis basically it is divided into on the basis of anatomical site on 6 types, like one will be the Rhino orbital cerebral mucormycosis, which I am going to discuss. Then second will be the pulmonary, third will be the cutaneous, then fourth will be gastrointestinal, disseminated and of uncommon site. Early diagnosis it will be the difficult because of the patient mount to host response or because of inconspicuous early symptoms and sign. So the purpose of my study is that to study the various clinical presentation of this mucormycosis patient presenting to ENT and ophthalm departments, and to find out the species distribution and treatment outcomes in patient of this group. So this study was carried out from June 2018 to February 20 in both ENT and ophthalmology department. So, and after obtaining clearance from ethical committee, and patient with clinical suspicions of mucormycosis were included. So in diagnostic we did nasal endoscopy and radiological examination, either CT or MRI of nose and PNS, orbit and cranium for all such patients. Then also tissue specimen was taken during endoscopic examination and sent for KOH mount. Then a patient with clinical suspicions and without laboratory confirmation were later excluded from study. Patient also underwent surgical treatment and antifungal administration at the after admission. Then the patient with disease progression who had died during the hospital treatment, they are considered as poor outcome, and patient was stable throughout the treatment. It is labeled as favorable or good outcome. So firstly we took 18 patients, but after that 2 patients were excluded because one came as a sinonasal malignancy and other was diagnosed with having aspergillus. So total 16 patients we have analyzed. So depending on age, 54 to 66 and 44 to 53 age group, they are most common, and the young age it is a little bit less on side. On females, they are on more side as compared to males. Then uncontrolled diabetes mellitus, they are having most vulnerable outcome. Then presenting symptoms like patient were most common were coming with swelling of the cheek and thick blunt stain discharge, like in 9 patients. Then rest of the patient they are coming associated symptoms like few are having visual disturbance, protrusion of eye, then pain over cheek and altered sensorium. Also nasal involvement more common. Ischial sites, then palatal and ophthalmoplegia were seen in 5 patients. Then we can see in more of ENT side there is sinus involvement also. On and off maxillary and ethmoidal sinus are most commonly involved. Then coming to species, we got Rhizopus species is mostly involved. Then what we give treatment, so all patients underwent repeated surgical debridement under endoscopic guidance, and along with that we have also started before treatment before result only amphotericin B after taking opinion from the nephrologist. Then orbital excitation was done in 7 patients and rhinectomy in 1 patient. Like I previously said, favorable outcome was seen only in 4 patients and unfavorable in 12 cases. And unfavorable was because of associated underlying symptoms some are having myocardial infarction, septicemia and progression also. So what is our discussion, like diabetic mellitus was the single most important risk factor. Then radiological investigation also helps in assessing the extension of disease and helps in the management of the disease. Then also rhizopus was the most common species what we got, and majority of the patients were not able to afford the costly amphotericin B formulation also. So that also went unfavorable outcome. So what is take home message or conclusion? It is like although mucormycosis is treatable condition, patient should be aware and it should be come in like early detected set early in early diagnosis, so that we can give proper management, and prompt suspicion and diagnosis is also needed. And empirical supported treatment can be initiated when it is the suspicion of the condition is present, and we don't have to wait till the reports come. Thank you.
So you have done the study before COVID.
Sorry, sir.
The study was done before COVID.
Post-COVID, sir. All those are post-COVID. 22, 23, like just after say first wave.
No, you said 18 to 20.
Sir, that's 20 post-COVID, sir. Like we started,
Pre-COVID.
but
Pre-COVID, na?
Pre-COVID.
Not after.
means not, but in between also we took that cases.
So because COVID is also a risk factor for
Yes, sir.
ROCM. So what do you want to messages for in cases of COVID, the presentation is little different. How it is different in COVID than the normal?
So basically they are having few patients are coming repeatedly, like they are giving proper history of COVID and newly detected mucormycosis, but on COVID history, like they have undergone intubation or such patients without any previous history, they are also getting like mucormycosis. It's like few cases we are getting now also. So we have to think about, we have to take proper history about COVID also, any prior history of COVID or anything that.
So is there any different presentation is different in COVID related cases or the normal?
No, sir, that much difference we didn't get. But post-COVID, we are getting more mucormycosis as compared to like pre-COVID.
Yes, actually in COVID, a lot of patients are presenting to the ophthalmologist first rather than into the ENT because they are having mainly orbital pain or periorbital swelling. That is the first presentation, many COVID related cases. Okay, fine.
Thanks.